All right, good. Okay, so hello to everybody and welcome to yet another session of the lecture series on IR Connect. For today's session, we have as the speaker Professor Phyllis Dakujeke. Professor Phyllis Dakujeke is with the University of Ghana School of Public Health, and also the lead for the African Regional Training Center. So Professor Phyllis Dakujeke is going to speak to us on effective ingredients of evidence-informed interventions. But before she comes in, may I ask everybody to kindly mute so that we give the floor to Professor Dakujeke. So, Prof, please take over now.
Thank you very much, Professor Sampong, for that kind introduction. Sorry, the poll is just sharing on my screen. It's just blinding me. Can it be taking off the poll so that I don't see it? It's blinding my screen. All right, so thank you very much, Prof. Asampong. My name has already been mentioned, and I hope you can all hear me. Good morning, good afternoon, depending on where we have joined from. I have joined you all from Accra, Ghana, and my task is to walk you through effective ingredients of evidence-informed interventions. I don't want to see the poll. It's needy. Is there a way that you can get the poll off my screen?
Yeah, I have disabled it. Oh.
Okay. Are they still showing though? Okay, so what we hope to achieve with this is that by the end of this session, we are hoping that we can all define core features of evidence-informed interventions. It is still showing. It is still showing. It's not allowing me to see my screen very well.
But I have disabled it. 1 second.
Am I the only one who can see the polls? Professor Sampo, can you see the poll?
No,
Yes.
I'm not able to see the poll.
It comes, but then
No, I have disabled the poll. Can you close it, or can you answer it and close it? I think it's mandatory, that's why.
Okay, sorry everyone. Yeah, it says share results, at least it's sharing. Stop sharing something. Let me pull the screen off for now and then let's see. Let me close it. Okay. Share the screen. Okay, all right. It's better now. Okay, thank you very much. All right, so I was saying that by the end of this 30-minute session that I've been given the opportunity to interact with you, I hope that we can all define core features of evidence-informed interventions, assess type of evidence-informing interventions, and also identify irrelevant, ineffective, or outmoded interventions to de-implement. So we start by looking at what are evidence-informed interventions. So we are considering what we call science-based tools with proving efficacy to improve health of populations. So collectively, we are looking at a group of items or a group of tools that are scientifically proven to be efficacious in improving health of populations in different angles. We look at it because in terms of efficacy, usually there would have been different levels of processes that have been used to collect evidence to indicate or to suggest that those tools are efficacious. And that multi-level of process for collecting that information or evidence can be based on research, practice, professional experience, clinical or community partners can all bring their ideas together and it becomes evidence for us to share. So what are some of the examples? So we can be, evidence-informed interventions can be programs, it can be practices, processes, policies, and guidelines. So any of these can sit comfortably as a type of evidence-informed intervention. I think that 2 weeks ago, when I joined, I heard Dr. Piyusha also speaking to evidence-informed interventions. So let's take this as more of emphasis of what she introduced you to. So we have defined it, what it is, and looked at examples of it. So what are the core components of an intervention? And in this case, what are the core components of evidence-informed interventions? We are looking at components that makes the intervention active. So we look at it as active ingredients. And first of all, they are supposed to specify the boundaries between activities that could be altered or not. And in this case, we are looking at, if it is an intervention, what are the components of the intervention that needs to be in place when it is being delivered? And when I say that needs to be in place, it means that those components cannot be compromised. Those components cannot be changed. And then we bunch it or compare it with activities or components of it that can be altered depending on the context within which it is being delivered. Also, some of the core components of an intervention that we need to consider is that we look at it as a basis for quality assurance. So in terms of having the intervention delivered within a space to ensure quality, to ensure fidelity, to ensure that the outcomes for delivering that intervention are the same or similar when you go to different contexts, then it means that those components should be in place to ensure quality. We also talk about the clinical interventions as against behavioral change interventions, especially when we consider the active ingredients, what can be altered, what cannot be altered, what forms the basis for quality assurance and all that. It's always good for us to look at clinical intervention as against behavioral change intervention. So for clinical interventions, it's easy for us to identify the core elements or the ingredients. So for instance, when we pick vaccines, we all know for a particular vaccine, for instance, COVID-19 vaccines, we know the number of dosages that an individual needs to take, even depending on the pharmaceutical company that produces it. In terms of the quantity, it is specified and it is usually within the jab itself. So it is easy for you to say that when it's a vaccine, when it's a therapeutic, like some of these medicines or technologies, it is easy for us to identify the key ingredients for that clinical intervention. It is not necessarily the case when we are looking at behavioral change interventions. They are a little, what should I say, vague in terms of the core components, in terms of the ingredients that needs to be in place. So we usually would say, or the literature would emphasize the fact that behavioral change interventions, when it comes to effective ingredients, are not easily discernible, which means that you cannot, when you pick a behavioral change intervention, it's not easy for you to say, for instance, the quantity is not that you need to have in place as an ingredient. It's not easy for you to say even the duration that you need to have it as an intervention. However, through research, there are 3 ways that you can still identify the key ingredients or the key components of an effective behavioral change intervention. And these 3, one is programmatic practice, 2, behavioral theory, and also through systematic research. Any of these can be used to identify the core components for a behavioral change intervention. And for us to really appreciate how it works, I'm going to share Galbraith's taxonomy for core elements when it comes to behavioral change interventions. So through his research, Galbraith and his colleagues have identified a number of, so they published this in 2011, and they have identified a number of core elements. You can say ingredients, effective ingredients, you can say core components, core features of an effective behavioral change intervention that needs to be in place for a successful implementation to take place. And for their taxonomy, they categorize it into 3. So 3 domains. They have the implementation domain, they have the content domain, and they also have the pedagogy domain. So allow me to settle here for a while because we have a lot of content on this. So I'll take my time to walk us through. For the taxonomy that Galbraith and colleagues present under implementation domain, they give us 19 items. They give us 19 items. And for these 19 items, it does not mean that all of it needs to be present before we can say that the intervention, the behavioral change intervention will be successful. At least when you have a few, then you are sure that it can work. And the implementation, we are looking at elements that logistically needs to be in place for the intervention to be delivered. So in this case, we are looking at logistics. We are looking at having a culture within a team to allow the implementation of the evidence-informed intervention. And they give examples, for instance, your ability to create a safe space for the delivery of the intervention, ensuring that you have a necessary support system, especially from your gatekeepers and also your stakeholders, selection of providers, volunteers to support the process. And then the list goes on and on. So you are supposed to have about 19 of this, and they have collated this from research of how different kinds of behavioral change interventions have been delivered within different contexts. From the implementation domain, we go to the content domain. And for the content domain, they give us 25 items under the content domain. And they cover a number of things. The content usually looks at the what of the intervention. So what components, what ingredients, what do you have to put in place as part of the intervention before you say that I am ready to go and deliver? And in that case, they bunch it up with a number of things. So for instance, do you have context that can influence positive intention to perform a protective behavior, for instance? Do you have content that address issues of feasibility within a social context? Do you have content that addresses influence skills that are necessary for the intervention to be rolled out? And then the list goes on and on. So out of this, they give us 25 items that need to be in place, especially in terms of content, enhancing coping skills, addressing gender norms, increasing ethnic pride. These are all examples that they give. Then the last one is the pedagogy domain. And the pedagogy domain, they give us 17 items. And for these 17 items under pedagogy, they look at the how, the process of delivery. So you have your content, you have your logistics in place, but when you go into a space, how do you deliver the intervention to the subpopulation of interest? And that they have examples like counseling, didactic lecture, testing for HIV, if it's an HIV-related intervention, use of electronic technology, and these are examples that you need to look out for. So how do you apply this taxonomy? By applying the taxonomy, let me just share an example with you that we picked. Mutri and colleagues in 2019 published a paper, and what they were looking at in South Africa was a nutrition education program that was being applied from a primary healthcare setting into another facility space. And for nutrition, education is one of the core components that you are supposed to have in terms of how to deal or how to manage diabetes amongst type 2 or type 1 diabetics within that space. And what they did was to apply Galbraith's taxonomy to that example to see which of these taxonomies in terms of the 3 categories, that is the content domain, the implementation domain, and also the pedagogy domain was at play. And from their study, they identified a few things. So to assess applicability of the NEP in a new setting, the study identified and evaluated core elements of the intervention. And they identified these 6. So 1, they realized that it had a group delivery format. So they had organized the intervention in such a way that it was delivered within a group setting. So not just a one-on-one, but within a group setting. And 2, face-to-face delivery, not online or any other alternative way of delivering the intervention, but they did face-to-face delivery, plus provision of education materials. They also identified the use of hands-on activities and demonstrations, cultural appropriateness of the NEP, follow-up intervention, and use of multiple behavioral change techniques. According to them, when you let this sit within the Galbraith taxonomy, then at least under all the 3 domains, you can have, right, a key or core components of it showing. So under implementation, cultural appropriateness, follow-up intervention, and provision of education materials are examples of a core ingredient that was identified as regarding this intervention, the NEP intervention. In terms of content, they use multiple behavioral change theories that are evidenced in dietary behavior. And we know when you are looking at diabetic patients and nutrition, this is also key. And as I mentioned earlier on, the pedagogy-based group format was used, face-to-face delivery, hands-on activities, and also demonstrations. Just to sum it up at this level, that the core components when it comes to behavioral change interventions, difficult for you to identify. However, when we learn from Galbraith and colleagues, there is a simple way for you to identify the core components of a behavioral change intervention when you look at the 3 domains of implementation, content, and also pedagogy. Now, the next thing that we are looking at as we consider the core elements or core ingredients of evidence-informed interventions is how do we really assess the type of evidence that is informing the intervention? Who is giving me feedback? How do we really assess evidence-informing interventions? So types of evidence-informing interventions. In public health, there are different kinds of evidence. But through literature, we realize that it comes in many forms in 3 broad domains or in 3 broad categories. So we can have evidence that speaks to us about the etiology and burden of disease. For instance, we can talk about evidence on effectiveness of the interventions. And for us in public health, and again, in implementation research, one of our key concerns is evidence on implementation within context. So not just one evidence. So all these 3 evidence, a lot of the times, is what we are interested in. And let's look at why we think that the evidence base should be broadened when we are looking at implementation research. So for informing evidence-informed interventions, we think that the evidence should be broader than just the type 1. And the type 1 is what I refer to as the etiology and then the burden of disease. So for evidence to inform us and for us to identify an intervention as being efficacious, effective, and can pass from one context to the other, yes, all these 3 types of evidence are necessary for us. One is a type 1, which looks at what and for whom, in what setting and under what conditions. So if you pick malaria, if you pick dengue, at least you should have enough evidence that tells you where the condition is prevalent, to what extent is it prevalent, in what conditions, under what settings are we looking at. And once you move from type 1, which is necessary because without it, you cannot actually implement the intervention. But once you understand the etiology and the burden of the disease, then you move on to the interventions that have been developed to address that condition. And that sets you into the type 2 evidence. The type 2 evidence looks at effectiveness of the interventions. And in this case, so if it is a particular intervention that has been developed, like ITNs, bed nets, for instance, if it's therapeutic, if it's medicinal, you want to see how effective it is within a particular context. And in that case, you are looking at effectiveness of the intervention. So you need to have enough evidence to support that this particular kind of intervention can be rolled up or rolled out to address a particular condition. And from that, we move on to implementation within a context that is the type 3. And that is where we suggest that the evidence base should be broadened. It is not just about etiology and burden, neither is it just about effectiveness, but it's also about context. And as we are here trying to understand implementation research, even looking at where we are all gathered and coming from, we know that the contexts are usually different, and it's important that we always acknowledge that. So the efficacy versus effectiveness evidence, most of us, looking at our background, be it clinical, medical, we are exposed to the randomized control efficacy trial, what we call the RTCs, which has become RCT, which has become the gold standard, and usually would control for potential confounding factors. It is done within a controlled setting, and tries to give you information or evidence about the efficacy of the intervention, which is a gold standard, as I mentioned, and it is one of the top ways of trying to identify if an intervention works or not. But when you move beyond that, implementation research is also interested in how one intervention adds to a range of interventions already being delivered within an existing environment. And what does that mean? That actually means that implementation research is interested in real-life contexts, and not a context or a scenario that controls for potential confounding factors. No, implementation research brings it into a routine space, routine service delivery space, routine service delivery context for you to study it. And in that case, we are all privy to that fact, and we know that interventions do not usually, we don't have like just one intervention being rolled out within a space at a particular point in time. There are multiple kinds of interventions that are running, even for just one condition. So if you are talking about dengue, if you are talking about malaria, if you are talking about diabetes, whatever you are talking about, you are looking at multiple. Some of them are clinical, while some of them are behavioral. And it's good that we identify that. In that case, implementation research says that let's push the evidence base, the need to expand the evidence, not just on how, but considering study designs, methods, strategies, the use of stakeholder inclusivity, and also outcomes. And by that, we broaden the evidence and say that, yes, at the end of the day, if we identify an intervention that works, we are comfortable because we use multiple study designs to arrive at that. We use multiple methodologies, strategies, stakeholders for them to support us arriving at a particular conclusion as an evidence for that intervention. Additionally, evidence on the iterated concept of ineffective interventions also needs to be considered, and that will be the last thing that I'll be talking about, how we have gotten to the level where we consider de-implementation and also misimplementation. Let me share this final one example before I move on to the de-implementation. So effectiveness of interventions, as I said, trying to expand the study designs when it comes to implementation research for us to gather enough evidence to support the effective rollout of particular interventions. So for example, if a study seeks to evaluate long-acting PrEP agents by demonstrating that it is non-inferior, so it is not inferior to daily oral dose for TDF or FTC, then we need to have a design, a research design that requires that it is delivered in a context where oral PrEP is also available. This actually means that we wouldn't have a lot of control because we are going to allow both interventions to be rolled out within a space for us to assess, right, how they contribute to each other in terms of addressing the issue of HIV. This is because the impact is best measured by its potential contribution in the context. That also includes the oral TDF. What this means is that implementation research is acknowledging the real-life context and the possibility of a large number of interventions that are being rolled out on the ground or also within a particular context. So now we look at the last one, which says, how do we identify irrelevant, ineffective, or outmoded interventions to de-implement? How do we identify irrelevant or ineffective or outmoded interventions to de-implement? Let me start by saying that when we all started looking at implementation research, we got so excited about the core components of an intervention and the fact that there is enough evidence to suggest that interventions work. So we put all our energies to it, and we want to make sure that it succeeds within our context. But it didn't take long for us to know that there are actually interventions that have been rolled out years back that are currently might not be needed within the context anymore. And that is where de-implementation comes in. Interventions to de-implement. Whenever we talk about implementation, let us also start thinking about de-implementation. So de-implementation basically looks at the discontinuation of interventions that needs to be stopped within a context. So discontinuation of interventions that needs to be stopped within a context. Largely, emerging evidence actually tells us that, like implementation, de-implementation occurs as a process. And the first of that process is a decision that needs to be taken. So a decision that needs to be taken within the policy space, within the guideline space, within the space of recommendations that are being made within a particular context. So in your countries, whether it's the Ministry of Health, whether it is the WHO office in collaboration with the Ministry of Health, that takes a decision to say that this kind of intervention is no longer needed within this space, or this kind of intervention needs to be stopped. That decision needs to be taken. But how do we arrive at that decision? So in identifying interventions appropriate for de-implementation, the following criteria is useful in arriving at the interventions that needs to be implemented. The first question that you ask yourself is, when interventions lack effectiveness or are harmful, are the interventions that you are considering, do they lack effectiveness or are they harmful to the populations that you are going or you are reaching out to, trying to address a particular health problem, which means that you are concerned at the end of the day, the possibility that instead of it supporting the health, is going to be harmful to the health of the population. The second is when more effective or efficient interventions become available. And that is something that over the years we have seen. So you pick a particular condition, and as technology improves, as research improves, as knowledge improves, we get to a point that particular kinds of interventions lose their effectiveness in comparison with earlier or in comparison with current ones that are being produced or that are coming into the same space. And lastly, the other point to consider is when the health or social issue of concern dissipates. When the health or social issue of concern dissipates, which means that it is no longer a problem for you to consider. So let me share an example and then that will be it. So I have two case examples. So for the last one, about when the health condition dissipates, I would want to use the SARS-CoV-2 virus, so COVID-19 as an example. With the introduction of vaccines and reduction in the spread of the virus, we all know and can attest from our different contexts and countries, continents, that the non-pharmaceutical interventions are no longer needed. And what do I mean? So we don't need to be doing lots of social distancing, neither do we need to be doing the lockdowns. So if we look at social distancing, if we look at lockdowns as examples of interventions, at this point in time, we are saying that in comparison with newer interventions, we do not need these kinds of interventions to run. And then the last one is a classic example of what we call the DARE, right? So the Drug Abuse Resistance Education Program said that in 2003, through research, it failed to demonstrate effectiveness using CDC standards. So with that, it's no longer considered as having enough evidence for it to be rolled out within different contexts to support people who are addicts for them to withdraw from drug abuse, more or less. So with that, let me conclude with some key messages. One, the core elements of an intervention are broadly categorized into three, especially when we are looking at behavior change interventions. So the domains are content, pedagogy, and implementation. And two, public health evidence comes in many forms, type 1, type 2, type 3, they are all important. But at this level with implementation research, we are pushing ourselves to broaden the base for the evidence, especially evidence that suggests that an intervention works. Implementation science increasingly recognize the importance of also understanding when it is appropriate for us to end the rollout of a particular intervention within a particular context. All right, so thank you very much for listening to me. So let me go back to Professor Ampong if there are questions for us to address.
All right, thank you very much, Dr. Kujeke. And I had put in the chat box that we can put in questions or comments, but as at now, there is no question there apart from a couple of inquiries about previous PowerPoints. I'm sure that will be addressed later on. But then there is a hand up. Let's see. Paul, please, let's have your question or comments.
Thank you. Thank you very much for the presentation. I have a question. So my question is, when you look at a program, a project cycle, I'm just wondering, how does this implementation research fit in and where does it fit in? For instance, if when you're starting, is it during the design of a project or an intervention, or when you're actually doing the inception phase of a project, or when the project is implemented and you want to sort of, is it part of the evaluation? I'm just trying to fit in where the implementation research fits into the project cycle of a program. Over.
Yeah, thank you, Anne-Marie. So let me see if I can rephrase your question, okay? And if it's fine as the question that you want answered, let me know. If not, then you can add on to it. So you are interested in knowing when to do an implementation research, whether at the inception phase, whether this phase where the program is ongoing, or at the end, more like an evaluation phase, right? Is that the question?
That is correct, yes.
Okay, all right. So let me attempt, okay. Okay, so when it comes to implementation research, what we have realized in studying it for a period now, or being involved in it for a period now, what we have realized is that you can do it at any stage in time. I remember a few years back when gene experts for use for TB was about to introduce, there was an implementation research to try to study its feasibility within this context. And that is at the beginning, right? That is one. And two, when you start rolling it out, you can still continue to do implementation research, especially when we realize that you have come against some bumps, you have come against some barriers, or you have also identified some facilitators that you want to take up opportunities of. And in that case, then it means that at that phase, the program is running, but you can do implementation research alongside it. When you are getting towards the end of it, you can also do implementation research as part of the evaluation of the processes that were used to enhance the rollout of the intervention. So my answer to you, Anne-Marie, is that it doesn't matter the where, but it depends on the implementation research question that you have, that you want answered. That will determine at which stage you would roll out the study.
All right. Yeah.
Thank
So
you
there's
very
another
much.
question from Elena. And so I read, as researchers on implementation, we often reach conclusions about interventions that should be continued or phased out, but cannot always reach decision makers to let them know what those are. What do you suggest we could do? So Phyllis, that's a question from Elena.
So Elena, thank you very much. I wish I could hear your voice asking me that question. And then, so, you know, what we have also come to realize is that stakeholder engagement is very important. And a lot of the times when we say stakeholder engagement, immediately our minds go to the communities, the end users of the interventions that we are considering. But we shouldn't forget that before an intervention is implemented within a space, it starts with the decision-making. And the decision-making comes from the top, from the policymakers. And stakeholder engagement then means that whilst we are thinking about involving or including the end user, we should also think about involving or including their policymakers, their practitioners, as we are doing implementation research. When we broaden the base to bring the policymakers, the practitioners, it becomes easy for them to adopt the findings or appreciate the findings that implementation research brings to them. And when that happens, then they are with us when we have suggestions about de-implementation. Elena, is it the same person with your hand up?
Yes.
Okay.
You said you wanted to hear my voice, so I figured
yes.
I would. The reason why I'm asking this question is because we have a particular study that we have recently done in Colombia regarding implementation of gene expert and other molecular tests for tuberculosis diagnosis. And what we have observed is that yes, GeneXpert and molecular tests are very good and they provide rapid results, but only in settings that have really those tests at hand easily. In very remote areas, that's not the truth, because the turnaround of the results comes late and it doesn't really result in rapid testing. Colombian government has issued recommendations for phasing out smear testing for tuberculosis diagnosis and implementing only molecular tests, but that it shouldn't be de-implemented yet, because we don't have a good penetration of the molecular tests yet. So that's where I'm coming from. And what we've thought is a policy brief. We have involved some decision makers from the beginning, policy make, but not just one person that has provided the time for us to explain what the project is about, and that's it. So I was just kind of wondering, or asking to pick your brain about how to, sort of get at a broader audience, or how to reach decision makers, policy makers in a more sort of systematic way, or maybe more efficacious, effective way. That's where I'm coming from with the question. Because sometimes, in developing countries like ours, policymakers have lots of things to do and don't necessarily make the time to listen to us researchers.
Yes, which is very true, Elena. So I like the flavor that you have added to it. So it is not just about involving the stakeholders, but it is also
Phyllis, are you on? Yeah, I think Phyllis must be having some technical challenge. Maybe some few minutes. I'm sure she will join. Let me try. Okay, so yes, I think she's trying to rejoin. So let me just put across this announcement even before she joins, that there will be a survey after you have exited. So when we are done, please take your time to fill out the survey, and then also be reminded that when everything is done, we will all take a group photograph, and that would mean that you would have to put on your videos so we can take a group photograph. Yeah. Yeah, so Phyllis will join us soon. So please take note of the following, that there will be a survey. The survey will appear when we have exited. Please, as much as possible, try and complete. That will help us, going forward to ensure that things are done right. And then also note that there will be a group photograph when we are done. There's a question. Let me see. Yeah, okay. There's a question from Vandalen. Not sure if Phyllis has rejoined. Okay, so Vandalen, I have taken note of your question, but this time your hand is up. So when she joins, please ask the question you put in the chat, and then any other question that you will have this time to present. All right. See. you joined? Please, have you been able to? Okay, so there is a question that was from Vandalen, and the question was that do we do implementation? I'm trying to paraphrase Vandalen, your question. Do we do implementation research only when a strategy has been proven to be effective?
Okay, do we do implementation research only when the strategy has been proven to be effective?
Yes.
So let me start by saying, apologizing, and I'm sorry about this. I was going to give another perspective that maybe after here we can pick up the conversation and continue on that. So the question about whether an intervention has been proven to be effective, let me even take it back to say that we do implementation research when the intervention has been proven to be efficacious, which means that it can address the problem for which it has been identified or for which it is being put to. So in that case, it requires a lot of evidence for us to arrive at that. Or else we will end up just implementing anything as an intervention. But an intervention within implementation research space means that there is evidence that speaks to the fact that that specific intervention has been proven to be efficacious within a space. The argument that implementation research is doing now is that once that one has been settled, then we move on to another level of evidence that it has been proven to be effective. So within a space, when it comes into a space, alongside other things that are being running, will it be effective? So efficacious is one, effectiveness is one, and the third one is when it is being implemented within a concept, considering all the contextual issues, can it still support in addressing the health condition that is of concern? So implementation research now, we are broadening the evidence. We are concerned or interested in different kinds of evidence to support the intervention that is being rolled out within the space.
Great. So there's this other question also from Vandalen. What difference exists between diffusion and dissemination in the adoption of an intervention?
This one, Professor Sample, you should be answering it. I don't think I touched on that.
Yeah.
I don't think I touched on that. So the question is about diffusion and dissemination.
Yeah.
I'll pass this, but I would have answered it in a very theoretical manner, not a very practical. But for example, if you can take a go at it.
Right. So I'm thinking that, yes, we will have, because this thing is being rolled out in series, we will have an opportunity when there will be a session on diffusion and dissemination, so we can concentrate on what was presented today. I think that should be fine for us. There's this other question. What are the uses and limits of in RMO studies? I'm not sure that one as well. Can we please mute? If you are not talking, please kindly mute. Yeah, so do we have any more questions? Let's see. Please, if there are questions, you can raise your hand or you put it in the chat. But I wanted to ask this question, Phyllis. I want to know who determines when an intervention is harmful such that there will be de-implementation. Will it be from the perspective of those who uptake the intervention or those who are implementing it?
Okay, so at this stage, the examples that I shared are all examples that indicate that the decision-making is more of a top-down change process. So top-down, meaning that we are looking at the policymakers, we are looking at the practitioners, and they're determining
whether an intervention is harmful or not. And then the decision is taken. Once the decision is taken, then they should come up with logistics that support the implementation process. So currently, that is how we are looking at it. But from the angle that you are asking, I'm also thinking about that their decision will be based on evidence. Their decision will be based on information. Sorry. Information that we have gathered. And I want to presume and believe that that information will also have something coming from the end user. So there is different ways of collecting information from end users when it comes to this. We know how within different spaces or content, adverse reports are given. Apart from adverse reports, the healthcare system itself also has a way of collecting information in terms of what is harmful. And it's also all important for us to consider at this stage in terms of the decision-making process as well. So yes, it is the policymaker, it is the practitioner, but I want to believe that their decision-making would also be based on information that they are gathering from the end users. But we shouldn't also forget that in all of this, it is not just that an intervention is harmful. That is why it is stopped. No, it is also when the social issue or the issue is no longer of concern to us.
All right.
Recording in progress.
Okay. Okay. All right. Thank you very much. Do we have any more questions? I'm sure we can take a couple of them. Please note there's opportunity to ask a couple of questions before we bring this session to an end. If anybody has a question or a comment, please, you have the floor. Okay. So Phyllis, let me also find out, you know, talking about the taxonomy and then making reference to the domains. Is it possible that, for example, how the content is, the implementation, and everything about the pedagogy that was, say, rolled out in, let's say, country A, be done in the same way in country B? Of course, when all the contextual issues have been taken into account. Is it something that is possible?
Okay, so that's a tough one to either say yes or no to. But what we have realized is that within different contexts, depending on what is already on the ground, then you can assess the effectiveness using or how the particular intervention is contributing to the success in addressing the health condition of concern here. And in that case, contextual issues, the way you address them will be based on how you identify them within a space. But largely, we have gotten to the point that we are saying that the evidence that we are gathering for implementing particular interventions within the particular spaces should be documented. And once we document it, then we can arrive at the extent, and I think that that is where the issues of internal validity and external validity comes in, which will be addressed in other sessions. How do we arrive at how the contextual issues contribute to the success of a particular kind of intervention being rolled out within a space?
All right, thank you very much. Do we have any last question? Right. So let me remind all of us again that a survey will appear when we exit. Please take your time to complete that. And then also we will have a group photo when we are done. And then also note that there will be the next session that will also take place next week, same time. The topic to be presented and the speaker, I'm sure, will be communicated in the course of the week. So at this point, let me say thank you to Professor Phyllis Darko-Jeke. This was a very insightful topic that you presented. And for all of you who are here, thank you so much. I mean, I know the times are very different depending on where you are. I see a hand. Maybe we can attend to that, and then we'll
we have one more question in the chat. Can you please
Oh, really? Okay. Okay. All right. So Phyllis.
I saw it. I was like, oh, is it late? Can I run
Okay.
away from this one?
Okay. All right. So please, there's a question from Yusuf. Can the effective ingredients of an intervention be adapted to different contexts or populations? If so, how can we ensure fidelity while optimizing for specific needs?
Yeah, thank you, Yusuf. I think that one of my earlier slides spoke to this, that we are looking at effective ingredients, but we are looking at it cautiously. The effective ingredients, there are a number of it. There are effective ingredients that cannot be compromised, that cannot be changed. And then they are the ones that we consider when we are looking at issues of fidelity. So how has it been designed in context A, that it has core components that those core components need to be transferred to context B. Those ones cannot be compromised. And there is a way of identifying those. However, there are effective ingredients that can be compromised. And when we say compromise, it's not as if you can let go of it or you can do whatever you want with it, but you can adapt it depending on the new context that you are going into. So depending on the intervention that you are considering, you should be able to balance the two, identify core components that ensure fidelity that cannot be compromised, and then core components that can be adapted or can be changed depending on the context that you are going into. And in all of this, as you have mentioned, it is the needs of the population that supersedes as you are making decisions in terms of balancing the act between those that can be changed and those that cannot be changed.
Great, thank you. Thank you very much. I can see one more. Okay, good.